You may begin the session.
Okay, thank you. So hello, everybody. I'm afraid we're missing our chair, so I'll just introduce myself. My name is Valerie Morin, and I'm a researcher at the Luxembourg Institute of Health and Luxembourg Institute of Socioeconomic Research. So my presentation today is on investigating the association between primary care efficiency and health system characteristics across European countries. I would like to acknowledge the financial support of the Luxembourg National Research Fund and also acknowledge the contribution of my co-authors. So in terms of background, so when we discuss efficiency, we may be referring to either allocative or technical efficiency. So in this presentation, we are concerned with technical efficiency. And previous studies have examined technical efficiency of health systems across countries, and they have looked at the overall health system. But it's important to be aware that while the overall health system may be inefficient, there may be sectors within the health system that are performing efficiently. And so therefore, it's also important to do sector level efficiency analyses. So many of the sector level studies, especially across countries, have tended to concentrate on hospitals because data is more readily available, and also because the hospital sector consumes a lot of resources. However, it's also important to look at primary care because it's often the first point of contact for people with the health system. It provides a comprehensive range of services, so not only treatment of illness, but also prevention and coordination of care. And it has the potential to improve efficiency, equity, and health outcomes. So the aims of this study are to see which health system characteristics are associated with the efficiency of primary care systems across European countries. And we also aim to contribute to the scarce evidence on this topic. We focus on diabetes because it has been used in previous studies of health system performance as a tracer condition, and there is a good evidence base for effective treatment, much of which can be delivered in a primary care setting. So we developed a conceptual framework to guide the analyses, and particularly in terms of the health system characteristics, we focused or we used the WHO health system building blocks. So the main method we used to calculate efficiency was data envelopment analysis. This is a very common method, especially for cross-country studies, as it is quite good in dealing with small sample sizes, which is often a characteristic of cross-country studies. However, disadvantages are that it can be sensitive to outliers and also measurement error. We also considered environmental determinants of efficiency. So these are factors which we could argue, at least in the short term, are outside the control of the primary care system that may affect performance and efficiency. So we deal with environmental variables in two ways. So the first way is to incorporate them directly into the DEA model as uncontrollable inputs. And then the second method is a two-stage analysis, whereby we compute the efficiency scores in the first stage, and then in a second stage, we regress the environmental variables against the efficiency scores. So in order to look at the association between efficiency and health system characteristics, we also use the two-stage analysis. So we regress the health system characteristics against the efficiency scores. And we use a double bootstrapping approach, which means that we use bootstrapped, or we calculate bootstrapped efficiency scores in the first stage to try to overcome some of the limitations in terms of outliers and measurement error. And then in the truncated regression, we use bootstrapped standard errors. So we draw on a number of international databases for our data. Our inputs are generalist medical practitioners, and we use two outputs: diabetes hospital admissions and admission-based diabetes lower extremity amputations. And then the environmental variables we consider are diabetes prevalence, smoking, obesity, and alcohol. Again, we use a number of different sources for our health system characteristics. And these include curative care beds, because we're considering admissions, pay for performance, gatekeeping, the organization of out-of-hours primary care, if nurses or assistants are involved in the provision of care for patients with chronic illness, diabetes registry, guidelines for diabetes, and the availability and use of e-health in primary care. So we estimate 4 models. In the first model, we just consider the input and outputs. And then in the subsequent models, we include the environmental variables, and we include smoking, obesity, and alcohol separately, primarily because we have quite a small sample size. So in terms of our results, so first of all, the DEA scores can range from 0 to 1, where 1 is the higher the better, so 1 is perfect efficiency. So because these are bootstrapped scores, we don't have any countries with values of 1. And we can also see that the inclusion of different environmental variables affects the DEA scores differently for different countries. So if we look at France and Germany, for example, we can see that when we control for smoking and alcohol consumption, their efficiency score improves. But for the Netherlands and Norway, these environmental variables do not really make a difference. The scores are quite robust across models. Then in terms of which health system characteristics play an important role, so we find that pay for performance and the routine checks of patients with chronic illness by nurses or assistants are associated with higher efficiency, and then a higher rate of curative care beds and weaker gatekeeping or fewer incentives to register with a primary care provider are associated with lower efficiency. So in terms of the discussion, we would like feedback, or we would welcome feedback on any part of the presentation, but some points that we have highlighted are our choice of methods to incorporate environmental variables. If there are any additional important variables which we have not included, and then any insights into our results. So thank you very much. So now I'll hand over to Joanna.
Thank you, Valerie.
Thank you, Valerie. Di, thank you. I did not realize you're chairing. Thank you.
No, I'm not chair. Well, I just stepped in at very short notice. So just to help out. So yes, so Joanna is going to speak next, is she?
I'm the third, actually.
Oh, okay.
Yeah, I thought you were, so that's why. Okay, so I'm going to hand over to Aditi Damasura, and who works with BPJS, which is the insurance agency in Indonesia. So I wonder if you'd like to share your screen, and then we can get going with your presentation.
Okay.
Aditya?
Thank you, Di. Hello, everyone. I'd like to share my screen first.
Aditya is sharing his screen just to encourage people to start putting questions and comments in the chat. Over to you, Aditya.
Thank you, Jai. Hello, everyone. I'm Aditya. On the behalf of my colleagues here, there's Rahma Anindita and Chandra Ihda. We're from the Indonesia Social Security Agency for Health Sector, or BPJS Kesehatan. We would like to share an analysis of Indonesia's primary care e-referral on how did the horizontal referral policy affect hospital outpatient visits and make cost savings. Now, in the Indonesian National Health Security Program, the JKN program, primary care providers are actually the gatekeepers, but we have an issue here. More than 21,000 PCPs are contracted by Indonesia's BPJS Kesehatan, and they are obliged to deliver quality services to more than 223 million registered members. Now, the issue is that the referral ratio in 2018 was high. More than 15% of patients visiting primary care providers were referred to hospitals, while 4.4% of the total referrals were actually unnecessary referrals, meaning that those referrals could have been treated, or those cases could have been treated in the primary care settings. This caused an inefficiency of 51.2 trillion rupiahs, which increased 10.07% than that of 2017. Now, in Indonesia, we have characteristics among primary care providers throughout the nation. There are areas with primary care providers with more resources, and also on the other hand, there are primary care providers which are less resourceful. And as of September 2019, because of those issues, BPJS Kesehatan enacted a horizontal referral system. So usually in the vertical referral system, primary care providers would directly refer patients to the secondary care. But in the horizontal referral system, BPJS Kesehatan tries to encourage primary care with less resource facilities to refer patients to primary care with more resource facilities. Now, our study tries to analyze the cost benefit analysis and also other issues regarding the implementation of the policy. The methodology of this study is actually non-experimental. We use a big data analysis because all primary care providers, all 21,000 primary care providers, use a single application, primary care software application, to record all primary care services. So all data is from the primary care application program. We try to separate data from September 2019 to December 2019 as group 1 data, and as for group 2 data is from January 2020 to October 2020. We try to divide these data into 2 groups because we want to know whether the horizontal referral policy brings impact during the COVID-19 pandemic since January 2020. As a result, among 21,746 contracted primary care providers, 4,957 of them have implemented horizontal referrals from September 2019 to October 2020. Now we can see here in this figure that most primary care providers are concentrated in, most primary care providers implementing the system are concentrated in the islands of Java and Sumatra, which are quite logical because Java and Sumatra are the 2 most developed islands in Indonesia. As you can see, primary care providers outside Java and Sumatra is assumed to have less resource facility, therefore they might not be implementing the system fully. Now, if we look at this trend, we can see that there is an increasing trend of horizontal referrals. The number of cases increases from September 2019. Even during the COVID-19 pandemics from January 2020 till October 2020, the number also increases. On the other hand, vertical referral decreases. This shows that how horizontal referral system in the JKN program has quite enough tried to reduce the vertical referrals and also is robust during the COVID-19 pandemic. As I have stated before that the referral ratio is more than 15% in 2018, precisely 16.19% in September 2019. But due to the horizontal referral policy in October, November, and December 2019, the referral ratio was reduced to 15.53% in January 2020. Of course, there is a factor of the COVID-19 pandemic, but if we can see here, there's also a decreasing trend even during the COVID-19 pandemic. In order to analyze the cost-benefit, the efficiency of the horizontal referral system, we try to analyze the hospital outpatient visits, the number of hospital outpatient visits, because in Indonesia, the hospital outpatient visits are paid through DRG, somehow like a DRG system, diagnosis-related group. We call it Indonesia case-based groups. It's like a semi-fee-for-service. And in Indonesia, there are 4 types of pathways of patient to enter hospital outpatient visits. One is from referrals from primary care providers. Another one is from referrals from other hospitals, referrals from other specialists within the same hospital, and also from emergency unit. So we exclude number 2, 3, and 4, and we only focus on number 1, which is referrals from primary care providers. If we look at this graphic, we can see that the horizontal referral policy has an impact on the number of hospital outpatient visits by PCP referrals. So the proportion increases from 0.01% in September 2019 to 0.35% in October 2020. So during the pandemic, the horizontal referral policy has been implemented also, and the trend tends to increase until now, until October 2020. We analyze the cost savings of the horizontal referral policy by multiplying the number of the potential hospital visits which were altered by the horizontal referral policy. We see that data group 1 and data group 2 also shows a cost savings with an estimated cost savings of 25.9 billion rupiahs, or approximately $1.7 million from September 2019 to October 2020. As a conclusion, the big data analysis on Indonesia's BPJS Kesehatan e-referral system showed the horizontal referral policy reduced the numbers of patients referred to hospitals and thus creating cost savings even during the COVID-19 pandemic. Horizontal referral proposes collaboration among primary care providers, thus controlling unnecessary referrals to hospitals. And this also strengthens primary care providers as gatekeepers in the Social Security program. It is expected that further interventions to extend the numbers of primary care providers implementing horizontal referral and their nationwide distribution will take place, as we know that the primary care providers are dominated by those in Java and Sumatra. We hope that the government will take actions to provide more facilities for primary care providers outside Java and Sumatra. And furthermore, it is also essential to provide resources, trainings, and competence improvement for all primary care providers in the system. Thank you.
Great. Thank you very much, Aditya. That was a very interesting presentation. And thanks to both Valerie and Aditya for being so good in keeping to time. We're now going to move over to Joanna Pestana, who's from the Nova School of Business and Economics. And that is located in Portugal. And she is already sharing her screen. So thank you very much. We look forward to your presentation, and please add questions to the chat box.
Thank you very much. I hope you can hear me okay. Okay, thank you. I'm Joanna Pestana from Nova School of Business and Economics in Lisbon, and I'm here to present to you my joint work with my supervisor, Professor Pedro Pita Barros. The title of this work is Measuring Efficiency in Primary Care Management of Chronic Diseases, Maternal Health and Child Care. I want to emphasize that this is work in progress, so I would be very thankful for your comments and suggestions in the chat or after the presentation. So let me give you a short introduction of efficiency in primary care. I don't think I need this because Valerie made a great job in presenting this already, but let me tell you, regarding my understanding of the emerging consensus, that strengthening primary care improves quality of care, health disparities, and restrains the growth of healthcare spending. It's also agreed that there is some scope for efficiency gains, as we saw in Valerie's presentation, and here efficiency is defined as the extent to which health goals can be achieved in relationship to resources consumed. My focus here will be more on cost efficiency, also called allocative efficiency, which can be defined as the attempt to minimize the cost of obtaining a desired level of quality and quantity of health services at the lowest price. There have been introduced some instruments to improve efficiency in the outpatient sector, as presented before, and these include changes in the payment system, like the performance incentives, but other organizational changes, like team-based practices. So my objective here today is to show you a bit my challenge to study the cost function of the primary healthcare providers in Portugal, and in particular to assess the relationship between the organizational models, different models which are governing the practices today, and the cost efficiency of these teams. So I'm using estimates of a stochastic cost function and efficient effects models as the prior studies. I'm adjusting for environmental factors, and I'm trying as much as possible to use activity-oriented as well as a quality-oriented perspective. Let me give you a short introduction of the context where this practice operate. So we are looking at the national public primary care providers in Portugal. Those are the main providers of primary care in Portugal. They also initially free and financed by taxes, and the workers are mostly civil servants. So since the reform in 2006, GPs could create their own team voluntarily. They could get together, hire the nurses and assistants they would need, and create a so-called family health units. These are team-based practices with more autonomy, and they were entitled to receive team incentives upon good performance. After a couple of years, they could apply to move into a more developed stage, the so-called family health unit type B, with more demanding targets and a larger patient list. And here they will receive a full P4P type of incentive, so financial monetary incentives to each professional related to their performance. Currently, the number of family health units has been increasing, so approximately 60% of the population is covered by these team-based practices, with and without individual incentives, but there's still a large amount of population still using the regular providers, plus there is some asymmetries in the distribution of the practices nationwide, especially focused on the most populated areas. So let me just show you the methods we've used. In this paper, we are using a cost frontier analysis. So we assume a short-run cost minimization function using the total costs, and here we include practice costs, salaries, subsidies, incentives, but also physician-induced expenditures on drugs and diagnostic tests. And we use two output variables. So on the one hand, we use four output variables, We use a volume perspective, so the common number of physician and nurses visits to the practice. And on the second hand, we use a quality perspective. So we use three output variables, which are indexes of adequate care. These are a compilation of intermediate outcomes and process indicators, especially for diabetes care, pregnant women, and children until the age of 2. As a price, we use the average wage of professionals in the practice. We estimate the cost function using stochastic frontier analysis for panel data, which estimates the best practice frontier through maximum likelihood estimation. And we include as well environmental factors, as well as 2 demi-variables, which account for a type of practice. And they will give us, so to say, or allow us to test the hypothesis that these units might in fact have a different cost frontier using the common error structure for the entire sector. The advantage of this approach is that it allows to separate between statistical noise and an efficiency term. And in this context, we use an efficiency term, we assume it to be time variant and having a truncated normal distribution. And we also include a couple of factors affecting the deviation from the cost frontier, which also include a type of practice. So running through the methods, I like to just highlight that I'm just presenting 2 models. So the model of only considering volume and the model considering volume and quality. And we see the cost elasticities and the product output elasticities are more or less what we would expect. So I'm going to move to the dummies, which give us then the possibility of a different cost frontier. So if we consider the first model, so only volume of production, we observe that for the same number of visits, the cost frontier of these family health units lay on average beneath the frontier as compared to the salaried model. And this is given by the negative coefficient of the marginal effect. But if we look at the effects per decile production, we see that the savings are made by this type of units are mostly concentrated in the large units, so above the 5th decile of production. This indicates that despite incentives payments, large ML units achieve the same volume of visits with a relatively lower cost, but the small family health units are not different from the salaried models. Now, if we control for quality and using the second model, having volume and quality, we observe that the family health units, in particular those more advanced, so the type B, in this case, they have on average associated with a higher cost for achieving the same volume and quality. And if we look at the scale of different scales of production, we see that this occurs particularly at small scale of production. So this means that for large scale of production, family health units don't differ in costs to the salary models when we account for their quality and quantity produced. So finally, look at the inefficiency, so the allocative inefficiency. And here we see that the gene-based models, so the family health units are associated with a smaller deviation from the frontier. And they are therefore more efficient than the salaried models. But here in general, as Valerie already showed, we achieve very high on average values of efficiency. So on average, the sector is 0.89 efficiency, and those in the family health units are among with the highest efficiency. So I think it's time to wrap up. We can say that the organizations that were brought by this reform was successful in improving the efficiency of primary care practices. And we can conclude that after adjusting for the potential difference in the cost frontier, the family health units are indeed doing more, so providing more visits and achieving higher quality score. And they do so, though at a smaller teams are doing so at relatively higher cost. So the introduction of these family health units should not be expected to significantly reduce the sector costs in the short run, but we do nevertheless find that they improve efficiency. And this should be taken as a pinch of salt. So we are looking here at association. We cannot exclude selection since it's a voluntary scheme. So finally, some food for thought in terms of explanations and in terms of the challenges we are facing here. The reasons why they might have these cost advantages can be due to technical advances in production or more autonomy, thus better involvement of professionals in clinical governance. But it can also be due to improvement in reporting systems or changes in prescription behavior, which we cannot capture. And also there is some potential for some skill mix substitutions and production of multiple health services affecting this effect, which we can so far not account for. Having said that, I'm not available for your questions and comments, and I'd like to thank you for your attention and also for the financing from the European Union for this project. Thank you very much.
Great, thank you very much, Joanna. That was 3 excellent presentations. I can see that there are some questions in the chat box. So what I would suggest is we actually have quite a bit of time for discussion. So to make it a bit more engaged, rather than me reading out the questions in the chat, I wonder if, first of all, if Aditya could maybe turn on his camera, and then if people would like to actually pose questions. So Bruce, you've posed some questions, Bruce Hollingsworth. So possibly if you'd like to turn on your camera, you have, and if you could go ahead and just engage with the presenters. Thanks.
Okay, well, I guess my first, thank you, Di, and thanks for all the presentations, all really interesting, really enjoyed them, thank you. So my first question was for Val. Actually, it was 2, but then it turned into 3 questions, I think. So with Di's permission, I'll ask them all, and hopefully short answers. I don't know, but we have got a lot of time, I guess. So thank you very much. Great presentation. Now I know you talked about using diabetes as kind of the trace element for efficiency. I was just wondering how you decided on that. Was it a practical thing in that there was lots of data, you know, so you could do it? Would you rather have had something else or some other data to do that with? And this the setup of the model. I know it's difficult with the efficiency models, but if you set the model up so that you're looking at diabetes, and for for performance, you get paid for doing certain things. I know they do, and certainly in lots of systems for treating diabetes, and the pay for performance providers are going to come out as more efficient. So you're kind of, you know, setting it up, self-fulfilling prophecy or something. So anyway, you know, I know you've got data and you've got to do what you can with it. So anyway, I'll stop talking because it's your session, not mine. So I'd be very interested to hear more. Thank you.
Thank you, Bruce. That's really helpful feedback. So on the diabetes, we did consider some other ambulatory care sensitive conditions. So the choice around diabetes, it was partly informed by my co-author, Ellen Nolte, at the LSHTM. So she's bringing in more of the epidemiological public health perspective. And I guess it's partly, as I said, because there's a good evidence base for diabetes. And she has used it as a tracer condition in previous conditions. And also, yes, we had a little more data. I mean, we're limited because we're using OECD data, but for diabetes, there were more indicators. So that really drove the choice of diabetes. Yes, it's a good point on pay for performance, because we are looking specifically at pay for performance for the management of chronic illness. So that's something maybe we have to consider if it's appropriate. I noticed in the chat you asked about the paper, so I forgot to say this is a work in progress, but hopefully the paper after this session, when we take on feedback, we will be able to finalize it and submit it for publication. So thank you again, really helpful.
Thank you.
May I also raise the question to Valerie? Oh, sorry, I didn't raise my hand.
Yes. No, go for it, please, please.
Yeah, I was wondering if you look at access issues due to chronic problems in hiring physicians. So I'm thinking, I know in some European countries this is an issue more to some remote areas, but in other countries like the one I'm currently, hiring physicians can be a problem. So you could, for instance, look at the patients which don't have a physician not followed directly by a physician, for instance. a second question a bit related is that if you look anything about the skill mix and whether nurses are contributing or other professionals in the sector are contributing to these outcomes.
Thank you. Yes, again, really good points. So yeah, I'm not sure if we have a variable because we're using cross-country data, how much is available on patients having a regular physician or being followed, but I can certainly check. And yes, for the skill mix, it's really important, particularly for diabetes, primary care. So we do include a variable where we see if nurses or other or assistants are involved in the care, but we can certainly try to supplement that. Perhaps see if there's multidisciplinary teams or other variables. Thank you.
Great. Reem, I wonder if, I'm not sure if I'm pronouncing that correctly, but it looked like you had a question for Aditya. So please go ahead and
Yes, no, thanks. You pronounced my name perfectly. Thank you to all the speakers. My question is for Aditya. I just wanted to understand whether BPJS assesses the appropriateness of referrals, if they have maybe a definition of primary care sensitive conditions, and if they track which primary healthcare or the service availability at primary healthcare physicians. I know that in Indonesia, referral rate is something that you track in your performance-based capitation scheme. So I just wanted to understand whether horizontal referrals were also included in that referral rate target, just to understand the sort of incentive context here. Over.
Hello, Rim. Thanks for the question. So we assess the appropriateness of the referrals by our data. Our data shows the ICD or the diagnosis codes used by the primary care providers. Currently, in our application, software application, we use the ICD-10 diagnosis codes, and among thousands of those diagnosis codes, approximately 821 diagnosis codes are enlisted as a primary care diagnosis code, meaning that if primary care providers refer patients with those one of those 800 diagnosis codes, they would be adjusted in their pay for performance capitation system. That might answer one of your questions. Now, the second question is how we define sensitive conditions among the primary care providers. In BPJS Kesehatan, we have a detailed profilings of each primary care providers, including what facilities do they have? Do they have, for example, a stethoscope or not? And several other facilities, but I can't say the details because I really need to see the application again. But the point is that we have a profiling system which manages to record data on the facilities that they have and then where they are located. For example, are they located in an isolated area or whether they have internet networks. All of those data are recorded in our profiling, which are used to which we use to as a reference for data analysis for further policies. I think that will answer your question, Reem. Thank you.
Great, thanks for that. I'm going to ask Charles next because you also had a question for Reem, and then Lisa has her hand up.
Thanks.
Oh, sorry, not for Aditya rather than to Reem.
Yeah. No, well, I was just interested when you were passing there, you've managed to do this study coinciding with the extraordinary events of the last 2 years. And certainly the data I've seen in Ireland suggests huge changes in referral patterns that have happened as a result of hospital congestion, worries about infection and all those things. I just wondered how you could be sure that there was no that what you were observing wasn't simply a reaction to the external effects of the pandemic.
Oh, yeah, thank you, Charles. Well, we try to evaluate these data by dividing it into groups, data groups. One is before 2020, which is before the pandemics, and one is during the pandemics. Now, our data shows during the pandemics, the horizontal referral system has been implemented quite very well, although it might not show a large proportion, but it shows an increasing trend. So what I can say here is that the policy is being implemented with an increasing trend, but in order to determine whether these implementation are sole factors for the change of the referral habits, it might need a further research or further studies. I think that might answer your question, Charles.
People are
Charles,
being very...
did you want to?
No, I was just, I mean, I think it's a nicely conceived study. The problem is that there's so much noise at the moment in terms of what routine data are showing that I think you would almost certainly have to look some way after the most obvious effects of the pandemic have passed, because I know certainly in other studies I've been involved in, we've had a lot of problems in disentangling what were the short-term pandemic effects from the underlying trends that were changing.
Great. Elise, I saw your hand up.
Yes, thank you, Dai. Thank you to the three presenters for this really interesting session. I just wanted to reflect on the notion of horizontal referral that Aditya sort of mentioned and studied. And I wanted to put that in perspective with episode of care and bundled payments, which is where we're moving towards in a lot of countries. And I just wondered how that would work, because in most cases, it is vertical integration that we're seeking, where in effect, we want to integrate the hospital with primary care. Here, interestingly, we're going horizontally. And so I just wondered whether what the financial incentives are in Indonesia, and how, to Joanna, the idea of horizontal referrals might be relevant in the Portugal context. So it's just a question to both of you.
Okay, maybe I should answer first. Thank you, Liz, for the question. Concerning regarding the financial issues about horizontal referral, well, currently in the National Health Security Program, primary care providers are paid by capitation, which is kind of a lump sum based on how many registered members are registered in each primary care providers, and they are compensated through pay for performance capitation, as mentioned by Irene before. And for the hospitals, they are paid by IHEA or a semi-fee-for-service system. Now, as the incentive, well, BPJS Kesehatan does not have the authority to give an incentive outside the regulation, because all the authority is still in the hands of the Ministry of Health. But what we can provide, or what we can offer to the primary care providers, is that if they do not refer patients directly to hospital, they would have a better target achievement concerning the non-specialty referral ratio in the pay for performance key indicators. So it might help them to reduce their numbers of referral to hospitals, and therefore they are not compensated. Their capitation is not compensated. That might be the financial incentives for the primary care providers.
Great, Joanna.
Thank you for the question, Lisa. Can I ask for a clarification? So you asked me regarding the horizontal referrals and if they would have an impact on our cost function. You mean referrals from GPs to other professions within the primary care sector?
Yes, that's basically what Aditya was mentioning, and I just thought this, to a certain extent, is relevant to a large number of countries, but obviously it may lead to a lot of referrals backwards and forwards at horizontal level, which is a question that was already asked by Reem and others. But I just thought, you know, it might be interesting to reflect as to whether it is relevant to other countries, in particular, you know, in your case, Joanna.
Yeah. Well, that's interesting perspective, which I didn't have. I thought about vertical referrals, and I thought about how to include this cost, because currently, so again, to clarify the payment system, so physicians are also paid a salary. There's a bit of fee for services for domestic visits, for instance, but only in the family health units, they have this performance payment on top of their salary, which means that those in the first stage of family health units, they are in the limbo, so they are still salaried, working, having high targets, but they're not receiving any performance incentives. So working very hard to move into the B type of model in which they'll get these incentives. So what happens, and regarding your question, is that indeed the issue here is that there are many patients without physicians. So there are many issues in hiring doctors. And so in some practices, this means that patients just go to any physician available, so there's no long-term relationship or any type of, so the care is done by different physicians. As for the family health units, we do have within the practice, when someone is missing, so the other physician takes over, and we also see a long relationship, which is something I don't account for here in this model. I also would like to answer to Bruce's prior question. Maybe I have the chance to do that. You asked me why did I choose this model, and as compared to non-parametric methods. The issue here was, apart from my supervisor's preference, which was also the first drive in the first place, but we have a large sample, so we have a panel data of all the practices in the country, and also when I understood the idea was to separate between the inefficiency and the environmental factors, and we want to really specify what was affecting inefficiency, and to see if particular model considerations like the skill mix and the type of model were affecting efficiency. Moreover, I also understood that DA model are more prone to outliers, and I must say, especially in remote areas, these small units are very prone to outliers. I didn't refer this, but I had to clean lots of practices, for instance, those which are in integrated care settings, which are some experience along the country, and also those which have only less than one physician or part-time physicians. I don't know if this answers your question.
Could I just follow up on that? Perhaps just ask if Val could explain why she chose not to use a parametric model. My heart's always been with the parametric models and my head's with the non-parametric ones.
Thank you, Charles. I think Joanna partly answered it, so I will piggyback off her answer. So because we have a small sample, we have some panel data, but I think it's really the small sample. So we did not, I mean, our first instinct was to go with the DEA model, primarily because that's what's been used in previous studies examining efficiency across countries. But we could consider the SFA. I'm not sure if it will be feasible, but yeah, maybe we shouldn't just ignore it. Thank you.
Great. I saw Bruce and Reem had their hands up, and please, anyone else who would like to ask questions, please do. But I'm going to suggest that both Bruce and Reem ask their questions, and then we allow the presenters to respond to both.
I think Reem definitely had a hand. Reem, you definitely had your hand up first, so you should go first.
Okay.
But then I quickly took it down because I think Aditya asked this, responded. It was more to understand whether on the performance-based capitation for the vertical referral versus the horizontal referral. I just wanted to clarify whether if a facility refers horizontally, does that get counted as part of their performance-based quota? Because I know it definitely counts for the vertical referral, but I just wanted to clarify if it counted for the horizontal referral. Thank you.
Okay, thank you, Rim. So in space indicators, horizontal referral is not does not explicitly or directly affect their performances in the P4P, but it affects how many vertical referrals they perform in the in the P4P performance. So they don't account directly, but it indirectly affects the vertical referrals.
Because it could be a way to kind of push out tricky cases without having to be counted in having the deduction come out from their performance-based capitation. So that's why I was kind of asking on whether you can track what facilities can actually deliver and hold them accountable to that before referring. But thank you for clarifying. Over.
Thank you, Rim.
Bruce?
So my question was really, so it was a practical question to Joanna about data. I'm sorry if I missed it in the presentation. How long a panel have you got? I think was my question. And secondly, I'd like to read your paper if it is available. That would be great if you've got somewhere we can look for it. But in following up to the modeling questions, I think you can't test for whether you should be using a parametric or non-parametric model for these types of models. I know you should probably use one for smaller samples and one for larger samples and different things, but that's often just guidance. So I often wonder whether you should just use both. Use the best one use the one that is most practical to present your results, and use the other one as a measure of robustness or validity or whatever you want to call it. It's nothing statistical really, it's just eyeballing the results. And if they didn't have results which pointed in similar directions and did similar things, I'd be pretty worried. So it's kind of a validity, robustness, whatever you want to call it, check. And it might end up as a footnote. But I always wonder, one is better for small samples, no doubt. One is better, the parametric's better for doing other certain things, including environmental variables, probably better. Okay, I agree with all that. But I often think, why not just use them both? If you've got your data sorted and everything set up, easy for me to say, obviously, it's not a small task. But my practical question was to Joanna really originally about the data. And sorry if I missed it in the presentation, how far before your intervention and after can you actually detect stuff? Thank you.
Thank you so much, and for the advice. If you're giving this best practice, then I definitely should take it, and I'm definitely going to include those on robustness checks. The data. So there was a bit of issue with the data in the last couple of months. I've been fighting to get this cost data because also due to the initiative. So the ministry here, they were asking to get these results in terms of costs and to know which was then a fair comparison between these models. The issue is that I don't have cost data that doesn't exist before intervention. So I only have data from 2016 to 2018. So this is a 3-year panel of data, which I had to do a couple of exclusions. So all these criteria explained, all those in integrated care, all those small practices or very large practices with never divided, and which were very different from the others. So I don't have before intervention data. And I don't think it's possible to have, since it happened in 2006, and since it's a voluntary model. This is a tricky issue here with selection, because definitely I will have issues of reverse causality, and probably this will introduce some upward bias in the results. But this is what we have to live with, given the time window we have available.
Great. Okay, so we've got 4 minutes formal time left. So I'm going to hand over to David to pose the final question, and then any final comments from the presenters.
Hi, thanks, Zai. My comment is related to Bruce's. Of course, Bruce is one of the biggest experts in efficiency, and actually one of my PhD examiners. So I should always be hearing, very interested what he has to say in this topic. Well, my question is, Bruce, also for Joanna. Of course, I mean, both methods have very different assumptions of DAA and stochastic frontier analysis. And of course, ideally, one would like that both, if you conduct both methods, they go in the same direction. But there has been a few studies in the literature that they actually, more commonly than not, they go in opposite directions. And then it's difficult to really try to interpret why is that happening. No, because and one of the reasons is that they are using very different assumptions. So just, I mean, it's a question for both Joanna, but also for Bruce, how to interpret when something goes in a different direction.
Yeah, I think Bruce can answer first.
All right. Well, look, if I had any data set and I ran an OLS on it or some descriptive stats or something, then I ran something else on it and the data and the answers were completely different, then I'd be going back to the data because there's probably something wrong with it or something wrong with me or what I've done with the regression or something. I just think if you run two similar techniques on a data set that you're pretty confident about, and it should come up with results that point in the same direction. There might be some outliers. There might be some different things because one's parametric and one's not. But if they don't come up with similar results with hospitals at the top or primary care units at the top mostly and at the bottom mostly, I'd be going back to my data and checking why that is. Is it for outliers? Is it for different reasons? What is it, you know? I'd be with then, because these techniques are 100% reliant on the data. So I'd be going straight back to the data and having a look to see what's going on. That's what I would do personally, but then I'm risk averse. So.
Yeah. Well, the issue here was in fact to, in the beginning, we were just trying to discuss, well, we're finding these differences and they are coming from this type of units having a different distance to the frontier, or is it that in fact they have a different frontier so that these units do produce, and it started with the discussion on technical frontier, and this is why we went first of all to the parametric models. As for the cost function, I definitely should test and see, and I'm thinking I might have aligned results. I haven't tested yet, but I'll let you know, Bruce, as soon as I test it, and both tests I will definitely provide you some feedback. Thank you very, very much. And thank you, David, for the question.
Great. I don't see any more hands raised or anything more in the chat box. So I'm going to end the session. I just want to say from my perspective, I wasn't intending coming to this session. I just stepped in to help out with moderating. And I'm very pleased that I did because I found it absolutely fascinating. And I thought that the engagement was very good. And I think it is really wonderful to actually have a session specifically focused on primary care and efficiency issues. Because the emphasis has been so much on hospitals during COVID, I think we really need to be putting a lot of attention on primary care to help balance things post-pandemic. But thank you very much to all three presenters for excellent presentations, and to everyone for participating and provoking thought and providing feedback. Thanks a lot.
Thank you very much.
Thank you very much.
Thank you.
Thank you, guys. Thank you, everyone.
Bye.
Cheers. Bye, everyone.
Thanks all. Bye.